Dr. Somaiah, thank you for meeting with me today for the end of the CTOS 2017 conference. I appreciate it. Dr. Somaiah is assistant professor at MD Anderson Cancer Center, Sarcoma Department. Thank you. Thank you.
It's a pleasure.
Dr. Somaiah, my question is, what makes LMS so difficult in terms of harnessing immunotherapy treatments as compared to other sarcoma subtypes?
Yeah, it's a little unfortunate that we haven't seen the responses we hoped in leiomyosarcoma patients, given that it is genomically pretty genomically unstable or sort of tumor. But I think right now there is not an answer there why the checkpoint inhibitors that are currently in clinical trials have not worked as expected. But the preclinical data that we're collecting from these clinical trials is going to be key to identify if one of the other inhibitors or agonists that are out there to enhance the immune system are going to help. Because I do think it is an immunogenic tumor, it's just that we're not either it's the T cells are not coming in or there's some other inhibitors in place that don't allow it to work. So I think, further research is going to help us to answer that question.
Thank you. And what is your view of aldoxorubicin coming online and its potential for a combination with olaratumab?
Well, aldoxorubicin is, obviously it's an active agent because it's doxorubicin, which we know has activity. And I think it would be reasonable if it is going to be, an agent that's available in market to do a combination with Olara, because I feel whatever mechanism of action that was with doxorubicin, that it potentiated doxorubicin's activity or had an effect in the stroma that helped patients live longer, that same effect could be translated in combination to aldoxorubicin.
Great. And as far as metabolic alterations in LMS, is there an important focus that could point to an increased treatment protocol?
You mean a kind of a treatment that
Yes.
would target LMS in particular?
Yeah.
I wish, of all the sequencing we have done so far, but again, this is sequencing only on the clinically available platforms, and I don't think it captures all the genomic alterations that are out there in LMS. So more in-depth sequencing for just LMS cohorts would be, more interesting to find out if there are other targetable alterations. But so far, nothing has come out as something that can be, that can be used as a biomarker for targeted therapy. However, I feel, we have the project with the CDK4 inhibitor sequential treatment going on, things like that, where it makes sense because chemotherapy is still the most sensitive, leiomyosarcoma is still most sensitive to chemotherapy, but to see how we can combine it better and I guess more sequencing in the future, trying to look at the whole genome and seeing if there's anything that we can find, would be helpful, but I don't think as of now in my sequencing, clinical sequencing, I have found anything that stands out for leiomyosarcoma.
Okay, thank you. And my last question is genomic profiling a viable standard of care inclusion? Is it being done at MD Anderson?
Yeah, we do that for all our patients. And again, if there's a patient who is resectable and with neoadjuvant therapy, I don't always do it because we're hoping those patients they won't come back and we won't need it. But majority of the other patients, especially if they come with recurrent disease or metastases, I order genomic profiling up front. I'm hoping in the future we'll have a more sarcoma-driven panel for genomic profiling because the panels available through Foundation and such, they are quite comprehensive. But they might not capture everything that is abnormal in sarcomas. But I think it is standard because even if it is only 5% cases I'm going to identify, or even 1% case I'm going to identify maybe an NTRK fusion, for me that's important if there is a targetable agent out there.
Good. Well, thank you so much for this. I really appreciate your time. Thank you very, very much, Dr. Somaiah.
Yes.